Okay, if you're revising for your anesthesiology exams, you know that pharmacology can feel like this huge mountain of just disconnected facts. Well, today, we're going to fix that. We are tackling antihypertensives, but not as some long list you have to memorize. Instead, we'll use a logical systems-based framework. This is the high-yield review you've been looking for, designed to actually make sense and stick. Let's get started.
Everything, and I mean everything, we're about to discuss comes back to this one simple yet incredibly powerful equation. Blood pressure equals cardiac output, that's how much blood the heart is pumping out, times systemic vascular resistance, which is basically the squeeze on all your blood vessels. Every single antihypertensive drug works by tweaking one or sometimes both of these variables. Keep this equation front and center in your mind. It's our blueprint for everything that follows.
So here's our game plan. We're going to organize this whole topic by the four main places these drugs work. First, the central nervous system, then the blood vessels, third is the heart, and finally, we'll hit the kidneys. And then, at the very end, we'll wrap it all up into a unified framework that is just perfect for exam recall.
All right, first stop, the command center, the central nervous system. The drugs that work here basically tell the brain to just chill out. They turn down the sympathetic or fight-or-flight response. So instead of trying to manage the effects way downstream, these drugs go right to the source of the signal.
And the main players in this category are, you guessed it, the centrally acting agents. You can think of these as the diplomats, persuading the brain to take a less aggressive approach to blood pressure control.
So how exactly do they work? Well, the key is that they stimulate these central alpha-2 adrenoceptors. Think of these receptors as an off switch, or a negative feedback loop right on the nerve ending. When you activate them, you trick the neuron into thinking there's already tons of noradrenaline out there, so it just dials back its own release. The result? Less sympathetic drive, lower SVR, and a drop in blood pressure. Simple as that. For your exams, the two classic examples you have to know are clonidine and methyldopa. And here's a little clinical pearl for you on clonidine. You have to be aware of significant rebound hypertension if you stop it suddenly. That is a classic exam question right there.
Okay, let's move from the command center down to the pipes themselves, the blood vessels. The drugs we're going to talk about here directly target that SVR side of our main equation. They do it by causing vasodilation, basically relaxing the smooth muscle in the vessel walls.
First up are the directly acting vasodilators. Now, these drugs have a really elegant mechanism for telling blood vessels to relax, and it all revolves around one very powerful little signaling molecule.
And this pathway is just beautiful. The drug donates a nitric oxide molecule. That nitric oxide then activates an enzyme called guanylate cyclase. This enzyme starts churning out a second messenger, cGMP. And it's this rise in cGMP that is the final signal for the muscle cell to relax. It's a clean, four-step cascade.
Now this is crucial. You have to know that not all direct vasodilators are the same. Look at this table. Some, like sodium nitroprusside, are balanced dilators. They relax both arteries and veins. This reduces both afterload, or SVR, and preload. But others, like GTN, are primarily venodilators. They mostly just reduce the preload coming back to the heart. And that distinction is absolutely vital in the clinic.
Okay, next we have vasodilators that work indirectly. They don't use that nitric oxide pathway we just talked about, but they get to the same end result, vessel relaxation, by targeting different receptors and channels on the smooth muscle cell itself.
And they do this in a few key ways. For your exams, the two most important ones to really get your head around are blocking calcium channels and blocking alpha receptors. It's also good to know that opening potassium channels and the effects of magnesium can also cause vasodilation.
Calcium channel blockers, like amlodipine, are wonderfully straightforward. Muscle needs calcium to contract, right? Well, by blocking the L-type calcium channels on the vascular smooth muscle, these drugs simply stop calcium from getting into the cell. What's the result? The muscle relaxes, and you get vasodilation. No calcium, no contraction.
And then we have our alpha blockers, like prazosin. Remember how noradrenaline causes vasoconstriction? It does that mainly by acting on alpha-1 adrenoceptors. So the logic here is simple. If you block that receptor, you block the vasoconstrictive signal, and that leads to both arterial and venous relaxation.
All right, on to our third pillar. We've tackled the brain and the blood vessels, both of which primarily mess with SVR. Now we're moving to the pump itself, the heart. The drugs that act here lower blood pressure by going after the cardiac output side of our big equation. And the undisputed champions of this category, a true exam favorite, are the beta-adrenoceptor antagonists, which we all know and love as beta blockers.
So their main job is to competitively block beta receptors in the heart. This does two key things. It causes negative inotropy, which means the heart contracts with less force, and negative chronotropy, slowing the heart rate down. Both of those directly cut down your cardiac output. But, and here's a crucial second point, they also reduce renin release from the kidneys, which hits another one of the body's key blood pressure systems that we'll talk about in just a minute.
Okay, this is a distinction you absolutely have to know cold, the difference between cardioselective and non-cardioselective beta blockers. Beta-1 receptors, they're mostly in the heart. Beta-2 receptors, they're in the lungs. So cardioselective agents like metoprolol mainly just target beta-1. But the non-cardioselective ones like propranolol block both, and that is why they can cause dangerous bronchospasm in patients with asthma.
And just to complete the picture, we've got the mixed antagonists. The classic example here is labetalol. This is a really clever drug because it combines non-cardioselective beta blockade with alpha-1 antagonism. So it reduces cardiac output through beta blockade, and it reduces systemic vascular resistance through alpha blockade. It's hitting both sides of our fundamental equation at the same time.
And that brings us to our fourth and final target, the kidneys. This organ is the master long-term regulator of blood pressure. It controls both the body's fluid volume and that incredibly powerful hormonal system known as the RAS.
The first and most intuitive class of drugs that work on the kidneys are, of course, the diuretics.
The main mechanism here is super simple. Diuretics make the body get rid of more salt and water. This reduces your total plasma volume, which in turn decreases preload, the amount of blood coming back to the heart. Less preload means a lower cardiac output. Fun fact, over the long term, some diuretics also have a secondary effect of causing a bit of arteriolar vasodilation, which helps lower SVR too.
The other major kidney-related target is the renin-angiotensin-aldosterone system, or RAAS. This whole hormonal cascade is an incredibly potent regulator of blood pressure. It all starts with renin, which leads to the formation of angiotensin 1. Then, the ACE enzyme converts that into the highly active angiotensin 2, which is a powerful vasoconstrictor and also stimulates aldosterone release.
And this is where two massive drug classes come into play. AC inhibitors, like ramipril, physically block the ACE enzyme, so they prevent angiotensin 2 from even being formed. On the other hand, angiotensin receptor antagonists, or ARBs, like losartan, they let angiotensin 2 be formed, but they block the receptors it's trying to act on. So it's two different ways to shut down the same powerful system. The big example? ACE inhibitors can cause that classic dry cough because they increase bradykinin levels. ARBs don't.
So there we have it. We have systematically walked through the 4 key targets. We've seen how these drugs can manipulate sympathetic outflow, vascular resistance, cardiac output, and fluid volume. Now, let's bring it all home and put these concepts together into a single, powerful framework.
And this right here, this is your money slide for revision. It lays everything out perfectly. The CNS and the blood vessel agents, they primarily reduce systemic vascular resistance. The agents acting on the heart, our beta blockers, primarily reduce cardiac output. And the kidneys, well, they're unique. They're the only target where we have drug classes that can effectively reduce both cardiac output through diuretics and systemic vascular resistance through the RAS agents. This is the whole big picture, right on one slide.
So let's leave you with a clinical challenge to apply this knowledge. You have a hypertensive patient in front of you who also has a history of severe bronchospasm. How does this framework guide your choice? Well, it immediately tells you to avoid anything with beta-2 effects, steering you clear of non-cardioselective beta blockers. That is the power of thinking in systems, not just memorizing lists. It's what turns knowledge into clinical wisdom. Thanks for joining me.